Latitude Food Allergy Care is pleased to host this roundtable discussion on children's nutrition with a focus on food anxiety and allergies. A few quick housekeeping items. All attendees are muted. This webinar will be recorded and available at a later date. Halfway through the webinar, we will open the conversation to live questions. Feel free to submit your questions in the Q&A panel at any time. You will have the option to submit questions anonymously, and please note that the physicians cannot answer specific personal medical questions. It is my pleasure to introduce Dr. Janesta Noland, Dr. Kellen Glinder, and Dr. Rani Maskatia. Dr. Noland and Dr. Glinder are both community pediatricians with private medical. Both physicians have decades of experience treating children, including many with asthma and allergies. And Dr. Maskatia is an allergist and immunologist who specializes in the diagnosis and treatment of food allergies at Latitude Food Allergy Care. To start us off, Janesta, can you provide us with a little context of where we are in this pandemic?
Yeah, thanks, Debbie. As of today, there are 5.6 million cases of the novel coronavirus in the United States. We have 1.7 million cases as of today, and we're just approaching 100,000 deaths. We're engaged in extraordinary lifestyle changes that we never could have anticipated. We've learned what it means to shelter in place, a term I never heard of before. We know what social distancing is now. And we're living in a society where all our businesses and restaurants are either very limited or entirely closed. So our life looks completely different than what we're used to. So it brings up the opportunity for a lot of anxiety, I think, where we might be nervous about our own health. We're certainly nervous about the health of our parents or more vulnerable members of our population. And we're in this strange place where our kids might not be able to see their grandparents out of concern for protecting more vulnerable people. We might be worried about our own ability to survive economically because our jobs might have either changed radically or gone completely away. We're trying to figure out how to homeschool our kids, and our kids are trying to figure out how to survive in a world where they don't get to hang out with their friends anymore. And now we get to worry about this new multi-system inflammatory syndrome in kids, which is more scary given that we initially thought that coronavirus was not a very serious disease in kids. So it's really a lot going on. And it's an interesting time in the world of people with food allergies. Just last Friday, the FDA loosened some of their regulations on food labeling, with an aim to minimize impact on sourcing of food. But it's still a very scary thing. We're going to come back to that. But I thought maybe I wanted to start because our world is so different, including how we engage with the medical profession. So I thought I would start maybe with both of you, Kellen and Rani. What does it look like to go see the doctor right now? Are you able to see patients? What are our offices like? How will it feel to somebody when they need to see the doctor?
Boy, we are in such a time of flux, aren't we? Who would have thought in February that we would be doing what we're doing now or have done what we've done? In many ways, all of this change has forced some incredible transitions and incredible collaborations. So thanks to everybody that's here. Thanks for Latitude hosting this webinar. And Rani, it's great to collaborate with you as we sort of open back up to the world. It's great to get our old teams back together. Late March and most of April was looking like a lot of Zoom calls, a lot of FaceTime calls, and a lot of distancing between patients and their providers. And we're lucky in the Bay Area that our overall incidence is very low, thanks in part to some early social distancing. And I also think thanks to some deep beliefs and trust in math and science. We trusted the predictions, and our schools closed down early. We social distance. You can see people wearing masks all over the place, and our culture has changed rapidly around us locally to kind of adapt to that. I think we'll be able to lean on those scientific pillars to open us up more. And I think this week has seen in my clinic and clinics in the community, pediatric clinics in the community, has seen a broadening of what we're able to do with in-person visits. Offices are adapting. I know in our office, we're actually changing scrubs between patients. We don't have a shortage of any PPE, so we're wearing masks for every time we're outside of our own room, when we see patients, when we interact with each other, and we're staying socially distanced as a medical care team, really focusing on keeping the care team and the patients safe and disease-free. Rani, what's going on at Latitude? How are you guys handling it at Latitude?
So similar to what you and Janesta have been alluding to, things are quite different now as compared to just even a few weeks or a few months ago. So we have been closely following the guidance from the state and from local health departments regarding clinic closures and now gradual reopening. So we did recently reopen with a lot of new measures in place to help improve safety for patients, but then also, of course, for the staff. So starting with universal masking, which of course, all offices in the area should be doing. In addition to that, we actually have a check-in station downstairs in our parking lot where we can kind of screen people. In our clinic, we actually don't see sick visits, and so we want to make sure that whoever is coming into our clinic, that we screen them for any potential symptoms and even check their temperatures to make sure that it's safe for them to enter our clinic. We have frequent, disinfection, as Kellen mentioned, lots of PPE being used right now. And luckily we have also not had any shortages of that, but just putting in lots of measures to keep everyone as safe as possible. We initially reopened to some of our more urgent visits, and in the last week have started to see some of our more regular visits, new patient visits. We started doing some food challenges and things. So gradually heading towards, full reopening. Of course, there are fewer patients in the clinic because we are also trying to maintain that physical distancing for staff, but then also for patients. So that does mean that there are less people in the clinic, which we did on purpose to adapt to some of these, new changes that we've put into place.
And Kellen, how does this sort of new way that we need to engage with our patients impact routine childhood vaccinations?
That is such an important topic. I think that for kids who are 5 and older, their routine vaccinations don't really get started again until somewhere in the 10 to 12 year range. And there's a little bit of slush there. So those kids can wait a few months, but definitely for infants and for toddlers, we can put kids at quite an increased risk if we miss routine immunizations. So that's for sure on the forefront of our mind. We kind of put that on hold for the last part of March and the early part of April. But very quickly, we started figuring out ways to bring those kids in and shelter them. And, really the idea, I think in our clinic, but also in a lot of the other community clinics, the idea is to sort of wrap those kids in a cocoon, sort of a metaphysical cocoon, to bring them into the clinic and get them out with very few interactions. And it's important to know that the medical teams are doing that so that families can feel comfortable enough to keep their kids safe. It would be awful to bring your kid in and then have them get sick because they came into the doctor. That just is counterintuitive. I know, Janesta, weren't you doing some things as well, some isolating things that were really creative?
Well, absolutely. I mean, we've given patients the choice, but many patients have elected to get their vaccines in their car in the parking lot, in the back parking lot, so that they didn't have to come into the office. We've also, offered some outdoor home visits for various indications so that the patient could stay outside in the open air. And I think we've even initiated, I don't know if I should say this out loud, allergy shots in the back parking lot, where we keep them in the car for the full 30-minute observation period. And many families have been delighted by not having to, wrestle 3 children into the office to get one child allergy shot. So anyway, it's been quite an interesting transition there.
Right. And I'm sure both of you will agree, in the past few months, I think all physicians have really increased their use of telehealth. And so that is how we were seeing patients while the clinics were closed. Now, of course, there are procedures and vaccinations and things that need to be done in person, which of course you will need to come to the clinic for, but we will continue to use our telemedicine platforms during this time for visits that don't require that in-person contact. And so that is another way that we've adjusted with this pandemic.
I'm loving this new tool of the telehealth visit. You know, I don't think it's just different than an in-person visit. Of course, you can't get as much information as out of a child on a telehealth visit, but you can involve family members in a much broader way and get a little bit interesting history in ways that you can't when you're seeing one parent in the clinic.
Absolutely.
That's interesting. So one of the things that we've been talking about amongst ourselves is using this opportunity where our lifestyle and where supply chains are radically different to think more about eating and nutrition. And I know, Kellen, you have some interesting ideas on this front. What would you like to share with us?
Yeah, I think, the Bay Area is usually one with abundance, right? It's got a lot of abundance in its weather and its climate, what grows here, the economy, and our children, by and large, that grow up with such abundance can sometimes suffer from not having a scarcity. And it is the scarcity of resources that breeds creativity. Sometimes it breeds ingenuity and grit. And so as our worlds have contracted, there's been a lot that's ripped out of children's lives. And there's a lot of grieving that happens with that. Those are real losses. If you're a junior or a senior in high school, you're not going to get your junior year or senior spring back. But anxiety is an equal opportunity employer, so to speak. And it doesn't really matter where your anxiety is coming from. When you're anxious, everything else that has potential to trigger anxiety can trigger it even more so. And so this is a time when people recoil from their usual restaurants, recoil from their usual food suppliers. And that I have seen trigger a ton of anxiety, and there is not a lot that an individual can do about that. But if we embrace it and say, this can be a gift in a weird, twisted way, we don't have many other choices, rather just embrace it. And rather than looking for the safe processed food, how about going upstream in the production and get raw ingredients and live like people lived 100 years ago, where you collect raw ingredients and you process your own food.
This is a meme that we found that I thought was appropriate at this moment.
After I've made my 100th dinner for my family, I think I'm feeling a whole lot like that. My kids are like, really? We're doing rice again, Dad?
Yeah. Well, I actually, in light of what you just said, I wonder if this is the time to talk a little bit about the FDA regulatory loosening that I mentioned earlier. I know this is something that's really concerning to food allergic families. Rani,
oh, sure.
Your thoughts on that?
Absolutely. So as Kellen mentioned, we know that this is a super anxious time for all families, really, with the changes in the routine and, not being able to, do the graduations and postponing some of those big events. This is a very anxiety provoking time for many families, but especially for families with food allergies. Already there's a higher level of anxiety when it comes to people that have food allergies. We know that through studies, they do have higher rates of anxiety, higher rates of depression, higher rates of bullying for kids with food allergies. There's even a study that showed that kids with food allergies actually have higher rates of anxiety and can have a lower quality of life than kids with type 1 diabetes. And so we know, just even in our regular circumstances that people with food allergies, do have these elevated rates of anxiety. Now, right now, there's been a whole bunch of additional things that have come up in the era of COVID-19 that have exacerbated those issues. So one of the things, and as Janesta alluded to, is that there have been some recent developments with regards to labeling laws. So really, this is brand new information, I just learned about it over the weekend even. But essentially, as we all know, there have been disruptions to the food industry in terms of supply chain issues and shortages of ingredients. And so the food industry essentially notified the FDA that they would have to be making some substitutions, when it comes to, certain ingredients and things in foods, and that they would not be able to reflect those substitutions in the labels on packages. As you can imagine, this is very anxiety provoking for our families with food allergies who have to be very, very careful about which foods, they ingest. And those labels are essential, accurate labels are essential to know whether there might be a potential allergen in that food. So, this has been a cause of much concern. The FDA has issued some guidance to the food industry, suggesting that, substitutions does not be made for the common allergenic foods. Those would include the top 8 allergenic foods: peanuts, tree nuts, milk, egg, wheat, soy, fish, and crustacean shellfish, but then also a couple of other foods that tend to cause allergy issues like sesame and mustard, for example. However, this is just guidance. Whether the food industry actually chooses to follow that is anyone's guess. And that's where the concern comes from for these families with food allergies. It was already hard enough, even with label reading, to try to avoid, accidental exposures. This does complicate things significantly and will be an additional source of anxiety. And as Kellen mentioned, this is a time where families may want to consider, cooking more at home and, not relying as much on packaged foods. This is supposed to be a temporary situation, but as with anything COVID related, we really don't know how long this might last for. And so these are issues that all families need to be aware of, but especially those with food allergies.
So on the topic of food allergies, there's an incredible burden that's experienced by kids and families with food allergies. You talked about the mental health burden, and and kids who've had anaphylaxis can also develop symptoms of PTSD, and I'm sure their parents can as well, because that's such a terrifying experience. There's a huge economic impact on families who may need to take time off of work to take care of their kids, or may need to find a different school setting for their kids. And then there's a huge health impact. There are something like 200,000 emergency room visits a year in the United States for allergy-related issues. 9,500 kids a year get hospitalized because of allergies. So it's something, kind of as a society to understand as a big actor, and something we need to take seriously. How do we know? I have two kind of questions that I'll sort of put together. How do we know when our kids have allergies, and what can we do to try to prevent the development of food allergies?
So yeah, if it's okay, I'll address the food allergy piece, and of course, Kellen, any additional information you have would be great in terms of how to to really tell whether this is allergy or whether this is another issue. So when it comes to allergic reactions, there are certain foods that are more associated with allergic reactions. I already listed them before, but essentially it's nuts, seafood, milk, eggs, soy, wheat are the top ones. And so those are the foods that those 8 foods really cause, 90% of allergic reactions. So those are the ones that we focused on the most. Of course, any food can cause an allergic reaction, but those are the most common ones that do. And when it comes to allergic reactions, there are some telltale signs that we look for. So for example, on the skin, there's a very distinct rash that we look for called hives. These are red, itchy welts that pop up on the skin. They respond really well to antihistamines, but even without treatment, they usually go away within a couple of hours, maybe up to 1 to 2 days, but they don't usually persist longer than that. And so that can help you distinguish whether this might be something allergic versus something that's not allergic. Same thing with GI symptoms. You can get all sorts of GI issues with food allergies, including stomach cramps and nausea, vomiting, diarrhea. But of course, that can happen outside of allergies also. I will say that even though it can happen, it's not common for GI issues to be the sole manifestation of an allergy. Usually you do have some additional symptoms like mouth itch or throat itch or hives on the skin. Usually there is something else that kind of tells you that this is an allergic reaction versus, another process. So that's kind of the criteria, that I use to determine whether this might be more of a food allergy type of situation versus something else. And of course, one of the most important things is that it happens in association with a particular food. So if you have a food allergy, you should be having those symptoms every time you eat the food. It shouldn't be, oh, sometimes I eat it and I get it, and then I eat that exact same amount of food another time and I don't get it. That doesn't really fit the picture of a food allergy. And Kellen, I'll let you,
I think those are all great things for the front line too. I mean, you're seeing patients upstream, but your expertise is so helpful on the front lines as well. But I would add to that what you were just saying, Rani, in that if you're going to have a reaction to a substance, whatever substance it is, the reaction is most likely going to be strongest where the concentration of the substance is highest. So for instance, if you eat a food, you put it in your mouth, you swallow it, and 4 days later you have a rash on your fingertips, that's probably not that related. And if it is, it's probably not that significant. If, however, you pick up something and within 3 minutes, you have swelling and itching and redness on your fingertips where those proteins are really high in concentration, that's a real thing to pay attention to quickly. And so when you eat something, where does that go? Well, it goes through your mouth. It goes all the way through your GI tract. So nausea, tingling, diarrhea, stomach ache, all of that stuff could be consistent with it. A lot of things will trigger that. But then if it gets absorbed into your bloodstream, then that can manifest with a host of things, hives being the big one. The other piece I would say about this, at this time when we're all so anxious, parenthetically, like the one thing I really enjoy in walking around right now, other than just getting away from everything, is we're all anxious and we can all see it now because you don't wear a mask unless you're anxious. So if you're asleep and your anxiety is 0, if you're anxious enough to put on a mask, which is a good thing right now, you can walk around and see we're all anxious. So we're all kind of jumpy and ready to go. And if you have a reaction and you're worried it could be a food or another substance, don't do that alone. Like, this is time to reach out to your care providers and at least do a phone call with somebody or a video chat. And if it's a chronic pattern, get help. Janesta, you said something to me right before we started, which I love. That little factoid was so perfect. And I want you to say it, but I'm going to tee you up for this and just acknowledge that the things we are most anxious about drive us the most crazy until we can actually acknowledge them. And once we get to that acknowledgement, even if it's a bad thing, then we're kind of already moving into dealing with it. So holding on to these things is really, really destroying us on the inside. So if you're worried you have a food reaction or any kind of reaction, contact your provider. And if you don't get the answers that you want or that you feel you need to help you feel better, keep asking. And that's what you guys do at Latitude so well. Is I've had so many patients that I think it might be a food reaction, but maybe not, but maybe the family is really, really worried about it more than I am, but I take that worry very seriously. And y'all at Latitude have been so great at helping patients feel better. So Janesta, I'm going to ask you to give us that factoid.
Well, I think what I said was that basically life is not free of suffering, and it is suffering. We have the opportunity, according to the Buddhists, to transform suffering into something that makes us better. But I read something that kids who do that food challenges, even if they are positive, decrease anxiety for the kid and for the families.
Right.
And that's the fascinating piece about this. So by just bringing it out into the open, it diminishes the fearsomeness of it.
I just want to echo that again, right? If somebody's in my clinic and they're worried that they're having a food reaction, even if I don't think it's a food reaction, I may try to prove that to them. But if I can't actually prove that to them and make them feel better, going through a food challenge will help that child cope with life. And right now we know our children are coping with way more than they should be coping with. And life kind of stinks for a lot of school-age kids right now. But if that really is a food allergy, and I'm kind of convinced that it's a food allergy, the faster I can get them to an allergist to do a food challenge is also going to help their mental health. I just think that's incredible. We have very few things that work that way.
Yeah,
absolutely.
And actually, Rani, I wanted that tease up something that I was hoping you would talk about, which is the diagnostic process. So
absolutely,
if somebody's worried their kid has allergies, and obviously, as Kellen is talking about, many people will go first to their pediatrician and hopefully make their way through the path to where they need to get. Although diagnosing food allergy is also a bit of a special thing.
Absolutely.
So talk to us a little bit about that.
Yeah, so it is surprising, but food allergies are notoriously difficult to diagnose. And one of the reasons has to do with the quality of our testing, which is validated and is good, but we do end up with a lot of false positives and things with our testing. And so it's not always very straightforward to diagnose a food allergy. The most important thing, of course, is, as Kellen mentioned, as you're mentioning, Janesta, is the history. You know, so there's usually some sort of history that makes people think that they might have a food allergy, and that's usually where we start, is just to take a very detailed history of what exactly happens, and seeing whether the pattern fits, those classic food allergy symptoms. Of course, food allergies can present in many ways, and so you want someone with a lot of experience that can really determine whether this is an allergic reaction or might be something else. And then we do rely on our testing to help us, but again, very important to have someone that really knows how to interpret that testing because of those rates of false positive. And so putting those two things together gives us an idea of what might be going on. There's a few cases where we can say, no, this really doesn't seem like it's a food allergic reaction, but a lot of times we don't know. And so in those cases where the diagnosis is unclear, we will perform these food challenges that both of you have alluded to. And what we do in a food challenge is, in a monitored setting in the clinic, we will actually give people the problematic food, the food that they're concerned about. We'll start with a really small amount and we'll gradually increase it over the course of, a few hours or so, and see what happens, okay? And so this, as you can imagine, this can be an anxiety-provoking type of situation, but as Janesta mentioned, we tend to do food challenges when we think there may not be a food allergy present. Of course, we're not perfect, and sometimes there will be allergic reactions. You're doing it in a monitored setting where the physicians are well equipped to deal with any degree of allergic reaction. And even in those food challenges where the kid does not pass, there is so much information gained from a food challenge. You can see how much did the child consume, child or adult. Of course, adults can have food allergies also. How much did they consume? What kind of reaction was it? How did we treat the reaction? There is so much valuable information and so much teaching that I can do during a food challenge that really, I feel, empowers families, so that if they run into a situation where there's an allergic reaction happening because of an accidental exposure or something, they will feel more confident in what they need to do to help their child, or help themselves, whatever that might be the case. And so food challenges, honestly, are one of the most rewarding things that I do. When someone passes a food challenge, fantastic. You don't need to worry about that food anymore. That's very liberating. But again, even when it doesn't go the way you might want, and even when there is a reaction during the challenge, that also is a very empowering experience for families.
Hey, Rani, I have a question for you.
Yeah.
Now that all of our kids are distance learning, it seems like this might be actually a good time for kids to come and spend 2-3 hours in your office getting a food challenge.
Yeah, exactly. So as I mentioned before, we are now open for food challenges, and so those are some of the appointments that we are providing. And yes, it might be easier to schedule now that there is some more flexibility for families to come in. Food challenges, they do take a while. They take about 3 to 4 hours, so that is a significant chunk of time. So it might be easier, yes, to fit that in during this time. What I also like to mention is in terms of prevention with Janesta, I think you alluded to that earlier in the talk. Unfortunately, there's been a lot of studies done on prevention of food allergies, and there aren't many things that have really panned out. Everything looking at probiotics and vitamin D supplementation, and do pets help? Well, so many things have been looked at with conflicting results in most cases. But the one thing that has actually been shown to prevent food allergies is early introduction of allergenic foods. So this is based on what you may have heard of, the LEAP trial, which was a very well-designed large-scale study that looked at infants that are at a higher risk of developing a peanut allergy. These were kids with moderate to severe eczema, and they may have already had an egg allergy. And so they are the highest risk infants. And what this study did is basically separate them into 2 groups. One group avoided peanuts, one group ate peanut early and often. These were infants between 4 and 11 months of age. And they did find that the group that consumed the peanut early and often, they ended up with an 86% reduction in rates of peanut allergy. So this was a very well-designed, very compelling study. And so this is the one thing right now that we can really hang our hats on to say that early introduction before 11 months of age really does seem to help prevent food allergies. And so those are kind of the more urgent food challenges that I was talking about. If a kid is at a higher risk of developing a food allergy, I do want to actually do those food challenges early on to get those foods into their diet in the hopes of prevention.
So what's an example of a child that you would want to do a food challenge on before the introduction of solid food?
Yeah, so that's an excellent question. So, the studies really did focus on those kids that are at higher risk. And so definitely kids that have, more severe eczema are at a higher risk of developing food allergies. We know that eczema is a risk factor for food allergies. And so those kids, I absolutely do recommend getting those foods into the diet early on. And of course, everyone should first discuss with their pediatricians and see, but there are cases where a child should really be seen by an allergist to have some preliminary allergy testing performed before those allergenic foods are introduced. So, I encourage everyone to have those discussions with their pediatricians, and if recommended, then to come see an allergist potentially for some testing beforehand. And sometimes we will even do those introductions in the clinic. If the testing is negative, if the kid is lower risk, doesn't have a history of eczema, for example, then a lot of times that can actually be done at home. But it's those kids with moderate to severe eczema and those kids that already have developed at least one food allergy, those are the ones that need to be most careful. Those are the ones in whom early introduction is the most beneficial. And so those are the ones that I do hope, everyone talks to their pediatrician about whether this is indicated.
So I want to clarify that a little bit. So a 4-month-old with eczema, but with no allergic family, no siblings with peanut allergy or anything like that, is that a child that you would recommend starts solid food, generally speaking, between 4 and 6 months? Or is that a child that you would like to see as an allergist to do testing?
So yeah, and this is a question that comes up, all the time. So it is a little bit confusing because the guidelines really say that if it's just mild eczema, then they may not be at an increased risk. It's those kids with more significant eczema that really should be seen by an allergist beforehand. And before, we used to think that, sibling history was very, very, very important. And, you know, kids with a sibling with a peanut allergy, all of them had to see an allergist beforehand. The newer guidelines actually suggest that the risk isn't that much higher. The eczema is a very well-known risk factor. And for, you know, obviously a family that has a child with a food allergy, they may themselves be very anxious about introducing some of these allergenic foods at home. And in that case, of course, it's appropriate to send them to us for reassurance and possibly even for testing, because that anxiety piece is something that we don't want to overlook. But technically speaking, it's those kids with more significant eczema or that have already had a food allergic reaction that are at the highest risk that really do benefit the most from early introduction. Now, Janesta, you mentioned, you know, that 4 to 6 month. So that I actually did want to spend a little bit of time talking about that, because as I mentioned in the LEAP study, that is what all of these guidelines are really based on, is that LEAP study. Those were kids between 4 and 11 months of age. And so they were not all 4 to 6 months of age, even though that's what some of the guidelines suggest right now, is that the earlier the better. They actually, though, had done a secondary analysis of the LEAP study, and they found that actually those kids in the older age group, the 6 to 11 month age group, if you introduce the foods during that age group, they actually seem to do better and have higher rates of tolerance as compared to the 4 to 6 month age group. So I don't want to draw too many conclusions from a secondary analysis, but regardless of say, we need more studies. There's no, you know, positive data saying that 4 to 6 months is going to be better than 6 to 11 months, for example. And so regardless, you know, of whether you do it at 4 months of age, or you do it at 6 months of age, or even if you do it at 11 months of age, regardless of that, it's important to know it's not just about introducing the food, it's about keeping the food in the diet on a regular basis. So in the LEAP study, they had them consume peanut 3 times a week. So that really, you know, as of right now, is the minimum that I would recommend of keeping allergenic foods in the diet. That, of course, can be difficult to do, so you do your best, but based on, you know, the studies that we have, it was frequent ingestion. So not just introducing the food and then just forgetting about it for the next 6 months. You got to keep it in the diet.
So do you recommend that families try to get all of those top 8 allergenic foods in their diet 3 times a week?
So that would be very, very challenging. So what I say is that the best data we have is for peanut, without a doubt. Okay. And so that is definitely one that I recommend. I did it with my own kids, you know, starting at around 6 months of age, got it in their diet, tried to keep it in their diet. So peanut is the one that we have the best data for. And we actually have very good data for egg also. So those would be the 2 that I absolutely say everyone should make it a point to try to get those foods into the diet and keep it in the diet of infants to hopefully prevent food allergies from forming. Now we extrapolate to all the other foods, but I'll be honest, you know, feeding a kid shrimp 3 times a week when they're 7 months old may not be the most, you know, may not be the easiest thing to do. So I ask you to do your best when it comes to those other foods. We are though really extrapolating from our experience with peanuts and egg to those other foods. It's not going to harm them in any way to keep those foods regularly in the diet, but you don't need to stress as much. We don't have as great data for seafood, for example. So I don't want you avoiding, you know, if the family eats seafood, then we want the child to be exposed to seafood, but it doesn't need to be as regimented as peanut and egg. And then, you know, so that's kind of how I approach it. It's never going to hurt to have a diverse diet. We know that in general, a diverse diet is going to have multiple benefits, but I don't want people stressing out and trying to fit, you know, 12 different foods into their kids' diet several times a week. That's really overwhelming.
I find in that sort of older infant age group, sort of the 8 to maybe 11-month-old age group, it's very helpful for families to be able to go to some of the local supermarkets that make soups every day.
Yeah, that's
and
true.
Just buy a crock of that, and if the family doesn't eat it, give their kid a little bit of that broth, even a couple times, 3 times a week. And that's kind of a good way to get these foods in. You get the seafood bisque,
right?
Vegetarian families that are willing to get some meat into their kids, just to make sure that they're able to tolerate that too. You could get like beef broth. You know, it's family by family, but the just buying it at the store, fresh made like that, it doesn't commit anybody to having to eat it. So
right. Absolutely. And I know a lot of families like to do, maybe not with the seafood, of course, but smoothies is a popular option also. And so, you know, just kind of blending together several of those nuts and peanuts and, you know, throwing some soy protein or whatever else into that, I know is another way that families like to get those allergenic foods in.
Just as a frontline doc, I wanted to go back and just sort of unwrap the doctor speak about severe eczema that the three of us are talking about.
Yeah.
And that, I find severe eczema is kind of like labor. It's like, do I have severe eczema? Do I have severe eczema? Do I have severe eczema? And
Right.
like, you know it when you have it. And if you're asking if you have it, you don't have it.
Right.
So, we see easily, in a busy clinic, you'll see eczema on, at least a few kids every day. And that is, I don't think that's the kind that we're going to really send to an allergist for a workup. But if your child is on multiple medications every day to try to control the eczema, and the eczema is now affecting sleep and is affecting your family life, that's probably as good a definition of any as when it becomes severe.
Absolutely. Absolutely.
And one of the things that you're saying, there's a lot of data around peanut, but we also know that peanut, correct me if I'm wrong, is an allergy that's less likely to resolve over time compared to other food allergies, which is a reason to be
extra vigilant.
Extra diligent with your peanut exposure. But one of the things I'm curious about is how allergies change over time, and how, when would it be indicated for a child to be retested? And because things can develop over time, and somebody might not have symptoms or allergy at one point, but have it at another point.
Yeah, so in general, when it comes to testing, one thing that we don't like to do is just kind of, blanket testing. So we really do try to focus the testing based on the history. So if a kid was consuming peanuts and has not had any issues, there really wouldn't be any indication to do any allergy testing, because they're eating the food, and because of that high rate of false positives that I talked about earlier, it wouldn't really give us any helpful information. Now, allergies do change over time, as you just mentioned. So we know that there are certain allergies that are likely to be outgrown. Those include things like milk and egg and soy and wheat. And so in those cases where a kid has a known allergy to those foods, we do test them regularly to see whether they might be, outgrowing some of those allergies. Ideally, you want to see that test, decreasing over time. And a lot of those kids do end up, the majority of those kids do end up outgrowing those allergies. And we test usually about once a year or so for those food allergies. There are other food allergies that are much less likely to be outgrown, including the peanuts, including the tree nuts, including seeds and seafood. And so those ones, we also do check the testing about once a year, but in general, we know that those rates of outgrowing are just much lower for those foods. So, compared to, 80% for the milk, egg, wheat, soy, we're looking at about 10 to 20% for the peanuts and tree nuts, and even less so for seafood. And so again, we do check about once a year or so in general, when a kid has an established food allergy. If they don't have a food allergy, then there's no reason to be doing the test, unless there's a concern about a new food allergy that may have popped up.
Yeah. One of the things I also wanted to go back to is skin rashes that we see in allergy. And in particular, I'm bringing up this question because of the time that we're in the midst of this giant pandemic. And we've all heard about skin rashes associated with COVID-19. And we're worrying also now about this new multi-system inflammatory syndrome in children. Kellen, would you like to talk about that a little bit?
Sure. So this multi-system inflammatory syndrome in children, MISC as it's now become called, is a very loosely defined condition where the inflammatory markers in a very small subset of children infected with the novel SARS-CoV-2 virus kind of spirals out of control. And there have been a couple hundred case reports throughout Europe, a gaggle of them in New York State. The first report in the U.S. actually came out of Lucille Packard Children's Hospital right here in our neighborhood, but then we haven't had any more. And it seems like it shows up several weeks, maybe 10 days into or after your initial infection. Oftentimes the infection of the virus is asymptomatic up until that point. And then your immune system really revs up and starts to cause inflammation. And inflammation is a very non-specific thing. We've been talking about how anxiety is non-specific, and I kind of view inflammation as sort of like anxiety,
In
and
the
that your
body.
biology kind of revs up, and that circulates through your bloodstream. The way anxiety would filter through a neighborhood, the inflammation can filter through your organs and rev everything up. And the organs that it affects, it seems like it's a little bit different in everybody, but you can get rashes in your skin. It may be that this thing, COVID toes, is actually a very, very, very mild version of this MIS-C. We have so much more we need to understand about this condition. It is very, very rare. And when things are very, very rare, it's hard to study them unless you're in a pandemic. But seeing as how we've had one child who may have had this in all of Northern California, I think the risk right now to our community about this is very, very small. The overwhelming amount of questions I've gotten from patients on rashes in their children is fueled by this anxiety, but there hasn't been anything that really looks inflammatory. But if you're starting to get purple on your digits, an achy pain, those are things that are obviously going to bother the patients who are having that sensation, and that stuff needs to be investigated and discussed, and if need be, examined. Mm-hmm. So, like I was saying with everything else, if this is happening to anybody's family members, don't fight it alone. Like, reach out for help.
Right.
Call your healthcare provider and have a conversation about what that actually means in your particular case.
All right, that's really helpful. Okay, back to this question of food allergies. We talked a lot about how to diagnose them, and now I'd like to talk about treatment. There was a peanut allergy treatment approved by the FDA in January, but this is a pretty interesting and fast-moving area right now.
Right. So it's actually, a very exciting time in the field of food allergy. For decades and decades, we had really not much to offer patients besides, avoiding and carrying an EpiPen. But now, more recently, there has been a lot of work in terms of trying to treat food allergies. And so most of the treatments center around this idea of immunotherapy. This is an idea that's been around for over 100 years in allergy. So basically, it's a process of desensitizing the body to the thing that it's allergic to. So what we do is we actually give the body small amounts of the thing that it's allergic to, and gradually over the course of months to years, we increase that amount until they reach a maintenance dose. So you may know of people that have gotten allergy shots. So if you have a cat allergy, you're actually getting cat antigen in that shot and slowly building the body's tolerance. With food allergies, we don't use injections, we use the actual food. So for example, if a patient has a peanut allergy, we will actually give them teeny tiny amounts of peanuts. Okay, such a low amount that it should not cause any reaction in the vast majority of people. And even if it does cause a reaction, it tends to be a very mild reaction. But we start with that really tiny amount, and we gradually, over the course of many months, get them eating more and more. And through this process, we're basically teaching the body to no longer react to the thing that it's allergic to. At the end of that several months, you reach what we call a maintenance dose that ends up being about the equivalent, about a peanut worth of protein. And then this is not a cure for allergies. This is a treatment for food allergies. So after you reach that maintenance dose, you actually would need to continue ingesting that maintenance dose on a very regular basis indefinitely. So daily dosing or near daily dosing should be expected for many years with this therapy. So, why do this therapy? So the main reason that people choose to do this therapy is to protect against accidental exposures. As diligent and careful as you are, there's always the chance for an accidental ingestion. So if you're eating a peanut every day without having an allergic reaction, the goal is that if you accidentally encounter a peanut in your day-to-day life, that you would be protected against that. You're usually protected to about 2 to 3 times the amount that you're consuming. And so that's really the main reason that people choose to do immunotherapy, is to protect against accidental exposures and thereby improve quality of life. So you don't need to be as anxious around situations that might lead to an accidental ingestion, because you have that layer of protection protection available. And so that's kind of the idea behind oral immunotherapy. At our clinic, we do offer oral immunotherapy for multiple different types of food allergies, including several different foods at once. We can actually treat multiple food allergies at one time. And as you just mentioned, Janesta, there was recently an FDA-approved option for peanut allergy specifically, which we will also be offering in our clinic. And so this is overall just a very, very exciting time for us in the field of food allergies, just because there are a lot of very exciting things happening. There's oral immunotherapy, there's a patch that's being evaluated right now as well that would just be placed on the skin and not require ingestion of the food. So lots of exciting things going on right now.
How many allergens can you desensitize a child to?
So ultimately, at one time, we try to limit it to about 5 or less. And that's based on studies that have come out of Stanford. That's really the place that has the most experience with treating multiple foods at once. And so we like to limit it to 5, but you can go through multiple courses. Of course, it does take a while, but that is a possibility for those rare kids that have many, many, many food allergies.
Interesting. I'm wondering if anyone has any questions for us. And if not, I have some more questions. Actually, I'll go ahead and ask this question. At what age is the best time to start OIT? And is there an advantage to making the diagnosis and starting OIT early?
Yeah, that is an excellent question. So we do have studies looking at younger kids with oral immunotherapy, specifically the preschool age, so 9 months to about 3 to 4 years of age. And those kids really do tend to do the best with immunotherapy. At those younger ages, the immune system is more malleable, and so they do seem to get the most beneficial changes to the immune system when they're younger, and they also tend to have less side effects from the therapy. Remember, with immunotherapy, we are giving kids something that they're allergic to. There is the risk of having allergic reactions. The majority of those are mild, mouth itching, throat itching, or stomach pain, but there can be more significant reactions as well. But it really seems like in those young kids, you see much fewer reactions and you get much better results overall. And as we talked about earlier, obviously there's a big mental health piece to food allergies. And in those younger kids, you really don't experience that as much either. It can be very difficult for some of our older kids to be eating the food that we've told them for years might kill them. So this is definitely something that's much easier to do in the younger population. We do treat older kids as well, of course, but those younger kids, they do tend to do quite well. So at our clinic, we treat 12 months of age and older.
Rani, would you treat an adult who's
Yes,
now working at home and now can work in your clinic?
Yeah. So we have treated a handful of adults. I will say it's less common for adults to seek out oral immunotherapy. Once you reach adulthood, a lot of people have just learned how to deal with their food allergies and just decide to continue avoiding. But we have had a couple of adults reach out, especially if they've continued to have these accidental ingestions into adulthood. That's when they really seem to be the most motivated to try therapy. Desensitization or oral immunotherapy, it does also work in adults, but it is more difficult. And I'm very honest about that. As you get older, your immune system gets more rigid and it can be a little bit more difficult. You got to be more diligent about that daily dosing. You got to be very strict about, the restrictions around the dose if you do decide to pursue this. But we have had adult patients have success with oral immunotherapy as well.
I have found that since I'm a pediatrician, the times that I recommend adults go get tested and explore this is when it starts to affect their children.
Mm-hmm. Yeah, that's a good point. I've actually had at least 2 situations, where parents have come in. In one case, just kind of they were trying to get these foods into their kid's diet, and so they themselves wanted to be protected while their kid is going to be around the foods that they're allergic to. And then in another case where it was a father and son who both happened to have the same food allergies and were thinking about pursuing desensitization together.
So once a child has gone through OIT, then they need to continue eating the food that they've been desensitized to in a specific prescribed way indefinitely?
Yeah, so as of right now, that is, that is what the studies suggest. Now, the younger population, like I said, they do seem to have more persistent benefits. These studies are pretty new, and so we need better long-term data to say whether, okay, is it truly, for years and years and years, or after a certain amount of time, can you decrease the dosing to 3 times a week instead of every day? Those studies are ongoing right now, and so hopefully we will have some better information about kind of what this therapy will look like long term. But anyone entering oral immunotherapy, I do tell them that the expectation should be that if you decide to pursue this therapy, that you need to be doing this maintenance dosing very, very long term, and that may change over time. But the expectation should be that this is going to continue long term, regardless of when it started. But we do have studies showing that it's those younger kids that really seem, when they've done the clinical trials and stopped the dosing for a period of several weeks, it looks like they actually maintain their protection even though the therapy was stopped for a few weeks. In general, if you stop therapy for a few weeks, in older populations like adults, you would lose all of the benefits of the desensitization. That doesn't seem to be the case in these preschoolers. But again, we need more data before we can really make stronger recommendations about what this looks like long term.
What do the data say about how long, when we're doing prevention, when we're doing, sort of early introduction of various allergens for prevention? You said 3 times a week. For what duration of time? What does the data suggest as how old a kid needs to keep eating everything?
Right, exactly. And these recommendations, of course, everyone should always remember we can only make recommendations as good as the research and the data that we have. So the way that the LEAP study was designed was 3 times a week, and they actually did that up until 5 years of age in those particular, in that particular study. That is the best study that we have to fall back on. Would it have worked if they only gave it twice a week for 3 years? Perhaps, we just don't know. And so as of right now, it's really in that preschool age that I ask parents to be the most diligent with trying to keep those foods in the diet. Of course, food allergies can pop up at any time, but it's most likely to happen in those younger years. And so that's the time that I want people to be the most careful in the hopes of preventing food allergies.
So we're almost out of time. I just want to ask Debbie if we have time for another question or two, or
yeah.
Are we...
I see a lot of questions are boiling up about oral immunotherapy. So of course, people have lots of questions about that. Maybe Janesta and Rani and Kellen, you guys could address one more. And then if people have additional questions, I'll leave up a contact slide at the end of this so that they can, reach out, and we are really more than happy to answer more questions, always.
So, okay, perfect. So, this is maybe too long of a question, but somebody's asking about the use of Zola or other biologics in the treatment and starting OIT.
Yeah, so we do sometimes use this medicine called Zola. Zola is an anti-IgE. IgE is the allergy antibody that floats around in the blood that is responsible for allergic reactions. So Zola is a medicine, an injection that basically brings down those IgE levels and brings down those allergic antibody levels. And so we know that it works to help decrease allergic reactions. It works really well in asthma, and it also helps prevent food allergic reactions. And so there have been studies, the most have come out of Stanford, looking at the combination of oral immunotherapy plus Zola to help reduce some of the side effects of oral immunotherapy. And the studies have been very promising, and especially for kids that have conditions like asthma, where they're requiring an inhaler on a daily basis. In those cases, I strongly do recommend the use of Zola to try to help prevent more serious reactions from oral immunotherapy from occurring. Zola doesn't seem to do much for the most common allergic reactions, which are those GI side effects, the stomach pain and things like that. It doesn't really seem to be doing so much to prevent those, but helping prevent the more serious reactions like the breathing issues and swelling and things like that, it does seem to be effective. And so in cases, I take it individually, of course, the vast majority of people don't seem to need Zola. But there are certain cases where I do recommend Xolair, and those would include those kids with asthma, sometimes kids with, multiple food allergies with really high IgE levels are another group that I will sometimes suggest using Xolair. Xolair is currently being looked at by the FDA to get approved for food allergies, but as of right now, it does not have an indication for food allergies, only for chronic hives and for moderate to severe asthma.
Great, thank you. Well, I want to be respectful of everyone's time, and this was really enlightening and a blast. I guess I will turn it back over to Debbie.
Yeah, thank you all so much. This was really, really a wonderful conversation, and really appreciate everyone's time staying on the call all the way through here. We will, like I said, have a recording that we will share with all the attendees hopefully soon, and I will try to quickly flash up here some contact information. Just see, hopefully everybody can see that. And again, if you had additional questions that were not answered, please reach out to the hello@latitudefac.com email, and we will be very happy to answer any additional questions. And thank you all so much.
Thank you very much.
Thank you.
Thanks, Debbie.